Good morning, everyone. On behalf of my good friend Ursula Karlukzai and Dr. Sylvester Veazey of the Friends of Hungary Foundation and John O'Sullivan, president of the Danube Institute, we welcome you to this conference on healthcare. Are there any lessons from abroad? We've gathered together experts, most on the front line of healthcare delivery from 3 different countries, who will examine the pluses and minuses of the Canadian, the US, and the Swedish systems. Finally, we will hear from a researcher who is not tied to any one system directly, but who researches medical systems globally. It seems no one in any country is pleased with their healthcare system. And as my dear husband once told me, healthcare is comprised of 3 components: cost containment, range of services, universal coverage. Pick any 2. Having all 3 is the challenge, and one that countries are currently grappling with. To begin the discussion, we'll be guided by our moderator, Marta Pintek. Marta is a true medical professional, both in private practice as well as in the classroom. Dr. Pintek is a professor of the Department of Health Economics, Faculty of Health Economics at Corvinus University of Budapest in Hungary, who's been very great in sponsoring this program. She's held this this position since 2015, and her history with the department goes back to 2009. She's been a senior consultant rheumatologist as well. She's actually been a practicing doctor and still practices medicine, and I believe is part-time on one of the hospital staffs. She's participated in numerous international research projects, has been published in scientific journals both in English and Hungarian languages, and she's received numerous awards in recognition of her writing, teaching, and presentation. So she'll be guiding us through our day, and afterwards we will have a good roundtable discussion. And without further ado, I turn it over to Dr. Pintek. Please join me in welcoming her.
Good morning, ladies and gentlemen. First, I would like to thank Danube Institute for inviting me to moderate this conference. I'm absolutely happy to be here, both as a physician and a professor of health economics. I have high interest in this field on healthcare system, and I really look forward to see what can we learn from abroad. First of all, I would like to introduce our invited speakers. I will provide a short bio of them, then I will give an overview of the program. The order will be by the program order of the introduction order. First, I would like to introduce Professor Antal Németh. He was born in Budapest, and he completed his studies in Budapest, Pannonhalma, then in Semmelweis University, University of Medicine in Hungary. He moved to Sweden in 1968 and started working as a pediatric gastroenterologist and hepatologist since 1980. He earned his PhD from the Karolinska Institute in 1982. He has been a professor for the Karolinska Institute since 2009 and is currently a senior professor. He served as a head of the pediatric gastroenterology department at Karolinska Hospital from 1990 to 2008. During that time, his unit became the largest pediatric hepatology center in Scandinavia, with children referred from all over Sweden and abroad alike. His main areas of interest include the clinical and experimental aspects of pediatric hepatology, cholestasis, autoimmunity, metabolic disorders, the liver-related aspects of pediatric pharmacology, chronic inflammations of the liver, liver transplantation in children, as well as its immunological and pharmacological aspects. Professor Németh received His Majesty the King's 12th Scythe Gold Medal in 1211. The second presenter will be Dr. István Szarka. István Szarka was born and raised in Budapest, then left Hungary and moved to Canada in 1965. In Canada, he obtained an engineering degree from McMaster University in 1977. Later, he was enrolled in the master's program of the university as an engineer. He completed it in 1979 along with the acquisition of the Electronic and Computer Sciences engineering degree, and began to work as an engineer. Later, he switched to medicine and got admitted to the Medical Studies Department of the McMaster University in Hamilton. He obtained his diploma in 1983, then decided to take on a 2-year family practice program. He opened his family practice the same year and has been in practicing ever since. Dr. Sarka was president of the Hamilton Medical Academy during 2015 and 16 as the first Hungarian-born president. Currently, he's a leading physician practitioner at the Family Health Organization while acting as a board member at the Ontario Family Health Group. He also participates in the board of the Chronic Patients Treatment Department, which specializes in diabetes in the Hamilton region within the Family Health Group. He is assistant clinical professor at the Family Practice Department of McMaster University. He also participates in the education and lecture circuit of the Department of Medicine and is one of the test reviews at the examination committee of the certification department of the Canadian Medical Council. Dr. Sándor Szabó. Dr. Sándor Szabó was a native of the Bácska region of northern Serbia and completed his primary level education in the town of Ada and attended the Hungarian high school in Szabadka before graduating from the Faculty of Medicine at Belgrade University. Subsequently, he immediately left for the institute led by János Seje, the Hungarian discoverer of stress at the University of Montreal, where he gained his PhD. Subsequently, he qualified as a pathologist at Harvard University, Boston. Continuing his research work began in Montreal on the molecular mechanisms, innovative treatment, and prevention of stomach and duodenum ulcer and other chronic illnesses related to stress. He remained at Harvard as an assistant and later as assistant professor. In the past 20 years, he has continued this life of research as a professor of pathology and pharmacology at the University of California, in addition to teaching medical students and resident doctors and serving as a medical doctor. In 2010, he was chosen as an external member of the Hungarian Academy of Sciences. Since 2015, Professor Szabó has been the president of the Association of the Hungarian American Academicians. Dr. Herrick, Devon Herrick. Dr. Herrick is a senior fellow at the National Center for Policy Analysis from the United States. His areas of specialty include the evolution of internet-based medicine, consumer-driven healthcare, and key changes in the global health market. He was among the first health policy analysts to identify and publish in-depth policy reports on consumerism in healthcare, including medical tourism, telemedicine, retail clinics, concierge medical practices, cosmetic medicine, shopping for drugs, and value-based health plan design. He has also researched personal technology and medical applications that empowers patients to better manage their medical needs. Dr. Herrick's expertise includes a variety of clinical health areas. Dr. Herrick speaks on health policy issues worldwide. His comments have appeared in hundreds of media outlets. He writes regularly on health policy for the National Center for Policy Analysis and other research organizations, and he's contributing editor of Healthcare News Journal. He served 2 terms as the chair of the Health Economics Roundtable of the National Association of Business Economics. Dr. Herrick has testified before the US Congress and before state legislatures. He began his career in healthcare financial management for a large healthcare system. Dr. Herrick received a Master of Public Affairs and a PhD in political economy from the University of Texas at Dallas. Dr. Herrick's dissertation research examined patient empowerment through empirical analysis of the internet and disease advocacy. He also holds advanced degrees in business and finance. So, dear guests, ladies and gentlemen, now we will start the program. And here in the morning, we will have a first session provided by 2 honored speakers, and we will get introduced to the 2 socialist medical models, Sweden and Canada, Let's see what's working well, what's working wrong, what can we learn from these countries. And first, I would like to invite Professor Antal Németh to provide his lecture. Thank you.
Thank you very much for the invitation, for the organizers. And you know by now who I am. And I have some disclosures. What I'm saying is based on 49 years of personal experience. Everything I say it reflects the views of the medical profession. And I know that not everybody will like what I say, but I believe that this American saying that call a spade is a very good thing, because then we can go on having an open discussion. And it's simplified due to lack of time, and I have no conflicts of interest to declare. The disposition of my talk is that first I will say some words about measuring healthcare productivity and quality. It's not my field, but I'm interested in it as a doctor. I will speak about the Swedish healthcare, and then will have some conclusions. Measuring quality and productivity of healthcare is very difficult. It has been going on for 200 years. There's no final consensus, but it's not impossible. And I chose one system. It's coming from Sweden. It's a private company who is running this system, and the result of it is called European Healthcare Index. And I like it because it's based on exact criteria, and it has been going on for a dozen of years, and you can follow the same country during the history. I call it a promising system. The company is called European Health Consumer Powerhouse, and the product of their work is the Healthcare Index, and they can give between 330 and 1,000 points per country. The ideal country has 1,000 points. The lost country has 330 points. And now for 2016, in order to be understood easier, they divided Europe into green countries, which have more than 800 points, yellow countries, which have between 600 and 800 points, and the red ones below 600 points. And they are examples for criteria they are looking for. Is accessibility, outcomes, nosocomial infections, range and reach of services provided, prevention, right to second opinion, pharmaceuticals, and a lot of others. But as you can see, they are very concrete criteria. What about Swedish healthcare? At that time, in the 1980s, 50s, there were no such systems, but everybody agreed that for about 30 years' time after the Second World War, Sweden was the leading #1 country in healthcare in the whole world. And they have not lost anything in the Second World War. They had a lot of money, and they could use this money very successfully, among others, for healthcare. And it was purely based on socialistic ideas. It was financed completely by taxpayers' money. It was governed by politicians, both central, in the United States you would call them federal, and local politicians. And it was produced by county councils. And everybody had to go to the same hospital depending on where he or she lived. And on the other hand, it was very difficult to see the price tag, because an appendectomy didn't cost the same in Budapest as in Szeged, because the local politicians spent some money for other things like public transportation, and then it was extremely difficult to calculate the price of the healthcare. It was based on the ideas of solidarity. Everybody had the right to it, poor people as well. It was equal rights in the medical things, and by the way, all the other things as well. You were not entitled to have your own room, you were not entitled to have your own food, and so on. Everybody had to have everything the same. And it was uniform, and you know this text from Marx. Everybody had to pay according to his or her ability, and for this everybody got according to the needs. So not depending on how much you paid. This is the basic principles of socialism. And the drawbacks of the system were it was monopolistic. There was only one provider in a place. Did you live here or there? Your postal address told you where you belong. And it was sometimes inhumanly egalitarian. No exceptions whatsoever. And foreigners couldn't swallow this system. There were very long waiting lists. Somebody said that if you would introduce socialism in Arabia, after 1 year there would be a shortage of sand. And it's the ever returning problem with socialism, that there were very long waiting lists, it was a low availability, it was very rigid. Orphan, everybody knows what orphan disease is, rare diseases. If you had an orphan disease and you lived in Szeged, if there was no expert on this field, bad for you. You had to move to a place where there were specialists on the field. And it's still so. However, people were very satisfied, very interestingly. Partly because of the Swedish system and the Swedish mentality. They like socialism in many ways. But what the main thing was that it delivered. It had excellent results. They implemented very early on, before the expression was found, the evidence-based medicine. And mostly on those fields where it suited well. It was evidence-based solutions. And I'm a pediatrician, so I'm taking an example from pediatrics. It's still so that Sweden is the absolutely outstanding #1 country in obstetrics and neonatal care. 2 months ago, the biggest German TV station, the ZDF, sent people to find out the secret of Sweden. And the secret is discipline. There are very few and relatively big centers. You have to travel up to 200 kilometers for delivering a child, and everybody accepts it, because you cannot have a delivery unit which has less than 10 deliveries per day, which is 3,500 deliveries per year. And the obstetrician is present only in less than 10% of the cases, while here everybody's waiting for the obstetrician to arrive by the taxi. But when he is needed, or she is needed, most of the obstetricians are women, then there's not only an obstetrician, but there is a pediatrician and an anesthetist and an operating room. So I've seen when the decision was taken for a caesarean section, and 8 minutes later the child was out. And that's why the rates of caesarean sections are lowest on the world, which is very good. And they have the lowest complication rate on the world, and by far the lowest maternal and infantile mortality on the world, and it's still so. And I still don't see a better solution than the Swedish one. But then, sometime, the decline started, and it starts always when it looks best. And I don't know how many of you read the book, The Rise and Fall of Modern Medicine, where you can see that it's the same thing for medicine as well. In the 80s, when it was brightest, then it started to decline. And what were the roots of decline? Some of the roots are exogenous, objective, and universal on the whole world. The aging population costs more money. There are new expensive diagnostic and therapeutic methods. New diagnosis, one MR apparatus costs zillions of money. New diagnosis and new risk groups with new diseases. And this is something that you have to accept. It's the development. But there are some very Swedish reasons as well. The shrinking possibilities to raise taxes. everything is tax-based, and you cannot take more than 100% tax from the people. And when you reach the 90% level, then it starts becoming a problem, how to raise more money. The politicians have a general desire for maximal control. They want to know everything about everything. And they don't trust the medical profession, so they want to control everything what the doctors do. Sometimes there were some scandals all around the world when a doctor bought something and got a lot of money privately, but it doesn't explain that the whole group of the whole medical profession would be so untrustworthy. And the next thing is what I call proletarization of the medical profession. It's the same thing they did 30 years earlier with the teachers. They proletarized the teachers, and now there's a shortage of teachers because it's not worth becoming a teacher. And the same thing is going on with the medical profession. And there is a statistical fury, unlimited computerization. And these are the main things what I see. Statistical fury. You have to fill in questionnaires all the time. They are A4, you know, the European standard size, 4 to 10 pages of A4 questionnaires to fill in for every patient. Especially the general practitioners are doing this. It deals with epidemiology, socioeconomic factors, gender aspects, ethnic aspects, treatment modalities, environmental impact of the treatment, and the red arrow means that sometimes it does make sense, but very often it doesn't make sense at all. So I call it information for no purpose. They just collect the information, and very good. It's very nice to have this information. And what's happening? Like this example, conflicting ambitions neutralize each other. One day you have to fill in a paper about the environmental aspects of the drug you're using. And it's very good to know that the Swedish fishes in the Swedish creeks are not getting feminized because all the products of the medical chemical industry are feminizing. Men have fewer spermia, the fishes are getting female, and so on. It's very good. But the day after, you get another letter that you have to give the cheapest synonymous drug to the patient. And maybe you don't know, but about 80% of the drugs in the world come from India. And in India, they have tubes like these just spitting out all the environmental poisons right out into the nature. So you take care of the Swedish environment and you forget about the Indian environment. So you're doing all these things for nothing because the complete sum will be the same. And just one example, I had Alagille syndrome is a typical pediatric hepatology diagnosis. It's a very severe disease sometimes, sometimes not. This child died at the age of 18 months. When he died, we had to produce 1,800 A4 pages of documentation. For what? This is nothing else but a cemetery of information. You cannot find anything, not even with your absolutely best and latest computer. Information for nothing, no purpose. Proletarization of the profession. There's a very poor development of wages for the doctors and especially for the nurses. And in the public sector, there are private companies where you have much higher salary, but the closer you come to the university hospital, the poorer your income is, and especially for nurses. The clinical and scientific skills do not boost your career. So you are a PhD, you are the best on something, and what does it play for all? Nothing. I always say that if you go to the opera house and you go there because Anna Netrebko is singing, then they tell you that, no, she's not here today. It's the CFO who is singing today. And because he is the one who has the highest salary. this is how hospitals work nowadays. And the medical profession, doctors and nurses, have a decreasing socio-economic status. And because they have lower salary, the hospital doesn't lose when they let doctors do the secretary's job. And it's always more and more so. And it does make sense, of course. And most of all, there is an enormous shortage of nurses, which leads to closed wards and a very low occupancy rate. The occupancy rate of a Swedish hospital is so low that if it would be a hotel, it would go bankrupt in 2 days. And the crumbling welfare. Always less and less diagnoses are covered by the insurance. They are called cosmetic surgery, for instance. If you have varices on your legs without ulceration, it's a cosmetic problem. Then the operation costs 2,000 euros, which you have paid above your taxes, what you have paid already. And less medicines are covered. There always more and more drugs are called OTC, over-the-counter drugs, and OTC drugs are not covered by insurance. And a very good example is diclofenac, Voltaren. It's a painkiller and anti-inflammatory drug with very severe side effects. OTC drug, you can buy it at the gas station, but you have to pay the whole price. And always less services are rendered. For instance, just one example. 1980, if you had your second child, you could go home when you wanted, but you could stay at the hospital for 5 days. Today you can stay for 5 hours, and you have to go. No question, you have to go home. And if you're not bleeding, go home, 5 hours. And above all these taxes, you have to pay always more and more for seeing a doctor, for spending a day at the hospital, and so on. So it costs always more and more above the taxpayers' money. And there are always more and more people. Today, close to 1 million, Sweden has a population of 10 million, close to 1 million people who have private insurance through their employees. As long as they are staying at this company, they have a private insurance. And it gives them a lot of advantages. And there are always more and more private producers. So altogether you can say that the public services do not meet the needs anymore. There's no money left. And now I come with the things what not everybody will like. The new managers, you know, the old managers, and there are some in Hungary, who were the old experienced doctors, the best surgeon, the best internal medicine person, who was the one who became the chairperson of the unit. Nowadays, the new managers have an average age of 35 years. And for instance, the second most important person in the Karolinska Hospital, who has a salary 3 times higher than the highest paid doctor, has 3 weeks of pediatric surgery behind him, 3 weeks. And they have very poor clinical and scientific skills, and because of that, they don't know what's going on in medicine. So they are not interested in research and development. And they spend their time with things they do not know, which they get from the above. They implement alien decisions. Earlier it was so that if the chairperson was an endocrinologist, then the clinic became an endocrine center. Today they don't even know what it is, and I can give you very concrete examples for this. What do? They control their colleagues. They control everything with the help of the computers. They can control everything what the doctors do, what kind of drugs they prescribe, how many patients they see, what kind of clinical chemical analysis they want to know, and that's what they do. And they do not take strategic decisions because they don't know it. The consequences are cost explosion, decreasing production, quality control instead of quality. And this is a very crucial, important, central piece. What is the quality that disappears? The time a doctor has to spend with the person behind the diagnosis. No time left. You have to go and write your quality control documentation. And there's a ongoing search for miracle solutions. Out goes the medical profession, in come new actors. If you take all the doctors of Japan together and look how many patients they see one day, then an average Japanese doctor sees 15 patients a day. And an average Swedish doctor sees 2 patients a day. And what are the destructive miracle solutions? And I mean this, although I know that many people here don't like what I say. You have to convert healthcare into production of goods. The ideal thing that we follow is Toyota, the holy Toyota. All these managers go to Toyota factories and look how the cars are built and how the outsourcing is going on and so on and so on and so on. And the problem, however, is that if a patient comes to you with 6 serious diagnoses, how do you convert this into 6 cars? And this is where the miracle solutions come. And the main models are new public management, which was going on in Sweden without that anybody gave this name for 15 years. Then somebody came and revealed that this is what we are doing. The next one is value-based medicine. And I know that the idea behind value-based medicine is very good, but they have failed to convince the medical profession that it's working. And everybody is seeing that this is nothing else but Toyota. And implementing evidence-based medicine on fields where they don't belong. Evidence-based medicine is working in obstetrics and neonatal ward, but it's not working in Alagille syndrome. And the new actors are consulting firms, the IT industry, and the construction industry. And it may sound very remote for Hungarian ears about the construction industry, but I will come back to it because it's very close to Hungary as well. Karolinska 2016, consulting fees paid for the equivalent for 700 nurses' yearly income to very concrete consulting firms, leading to what? You can see immediately. 2 European hospitals, Charité in Berlin, Karolinska in Stockholm. Why did I choose Charité? Because it has the same amount of employees as Karolinska, 15,000 employees. What does Charité do for this? There are 3,200 beds. Karolinska has less than 1,500 beds. The outpatient number is 1 million in Berlin. Nobody knows how many in Stockholm, because these figures are not so important. They don't want to know it. The inpatients, 128,000 in Berlin. Nobody knows how many in Stockholm. The construction costs, 0.3 to 0.5 billion euro in Germany, and 2.5 to 7 billion in Sweden. And what does it mean, this figure? Charité was actually built by Erich Honecker. It was only renovated. The German figures are coming from 2 newly built hospitals in Hamburg, Hamburg-Barmbek and Hamburg-Eppendorf. And they are comparable with the Karolinska Hospital. And their cost was 0.5 billion euros. The Karolinska can be counted differently. It can be 2.5 billion or 7 billion. What's the difference? The difference is PFI. And if you altogether is 30 times more expensive in Sweden than in Germany. What is PFI? PFI is the invasion of the healthcare by the construction industry. And it's called Private Financing Initiative. You have it in Canada. As far as I know, you have it in the United States. but above all, you have it in England. There are 6 or 7 newly built hospitals in England based on PFI. And Sweden has only 1 for the time being. I'm not an economist, I cannot explain it better than it's like wetting your pants. It gives you immediate relief and warmth, but very soon it turns cold and wet. Because you cannot see the price in this year's and next year's budget. And who will pay them? Your grandchildren will pay it. And then 2.5 will turn into 7 billion. 7 billion times 35, that's the price in Hungarian forints. So try to find out how much it is. Back to European Healthcare Index. Remember, green countries, yellow countries, and red countries. And if you look, it's, as expected, northwestern Europe is an ocean of green countries. There's one island of yellow, poor quality country, that's Sweden. The other one is England and Ireland, but that's another story, I'm not talking about it. If you look further down, there's one red island, unfortunately, in the ocean of yellow and green, that's Hungary. And if you see, we are surrounded, with the exception of Romania, all the countries around us are yellow or green. Austria is green. All the former Yugoslav countries, Czech Republic, Slovakia are yellow, which is higher level than Hungary. And that's why we are here, because this cannot go on. Something has to happen. Somehow Hungarian healthcare has to be turned around. So what are my general conclusions? Of course, economists, IT people, construction industry are important. Look around at the Hungarian hospitals and what a poor shape they are. But please, 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 cooperate with the medical staff. We have been doing this for decades. You cannot send a 30-year-old consultant who knows everything much better than we know. We know it better. You have to listen, and you have to follow our instructions. And don't come with new expressions that nobody understands. Because medicine is a complicated thing. And are there any lessons from abroad? Yes, of course they are. And my concrete suggestion to Hungary is that take 4 European countries and look at them. Take one green country, and my suggestion is Switzerland, which is the number 2 with 904 points. The number 1 country is Holland. But Switzerland is better than Holland because the Swiss health insurance system is cheaper than the Dutch one. Take 2 yellow countries, one successful and one unsuccessful. The successful one, the rising star in Europe, is today the Czech Republic. The Czech Republic is only 6 points behind Sweden, 2016, which means that next year, 2017, they will be ahead of Sweden because you cannot turn around things so easily. But the Czech Republic is a very good example, and Sweden is a very good example how not to do it because of the price and so on. And take one red country. And the advantage with the red country that you don't even have to pay for the travel because you can stay at home. Thank you for your attention.
Thank you very much. My suggestion is to let's listen to Professor Sabo, and then we will have a few questions and answers before the coffee break. Thank you very much. Maybe you can see better the screen from your place. So, 2 socialist medical models, Sweden and Canada, what's working, what's not. Thank you again for this excellent presentation. I hope it generated quite many questions. I found it really interesting. And now I would like to ask Stephen Starka, Dr. Stephen Starka from McMaster University to talk about the Canadian example. Thank you.
Tisztelt elnök asszony, kedves beszélgető barátaim! kollégák, köszönöm a lehetőséget, hogy megoszthatom önökkel a kanadai tapasztalataimat. Thank you very much for inviting me. I'm very honored to stand here in front of you with such esteemed colleagues. I'm always happy to address an audience of some mental quality and elevated social grace. Thank you for having me. Healthcare in Hungary, are there any lessons from abroad? Like the previous speaker, in Canada we always have to talk about conflicts of interest. And basically what this refers to is, are we getting any sort of any support from abroad? Are we getting paid? Unfortunately, I'm not. On the other hand, it goes well with the current topic, and that's socialized medicine, where you're getting something for nothing. So you guys are getting something for nothing, and I certainly hope it'll be better than your healthcare system, or ours for that matter. So before I begin my talk, I got a call from a fellow whom I'm sure you well know, and I told him I'm going to be speaking about the Hungarian healthcare system, and what does he think about that? And he thought, this is a really great idea. And I said, do you have any recommendations for me? Is there anything that you can help me with? He said, sure, I'll send you a hat. So, make Hungary great again. So we're talking about two socialist medical models. The gentleman beforehand, my esteemed colleague, talked about Sweden. My job is to talk about Canada, about what's working and what's not. So when I was approached, I said to Melissa, I said, you know, you've really picked the wrong doc. I said, I'm just a working doc, just the fellow you see there. I run around all day. I'm the guy who's working in the trenches. I don't make policies. I'm not very good with numbers. I don't know how many doctors per patient or dollars per capita. So I'm just a working guy. And she said, you know, that's who we want to hear from. There's somebody who works in the trenches to talk to us. What's it like practicing in Canada, and what are the good things, what are the bad things? So hence I put a slide together. And inevitably, whenever you talk about healthcare, or socialized healthcare for that matter, it reminds me, I'm sure you've seen the movie, I can see by the age of the audience, the movie called The Good, Bad, and the Ugly. And unfortunately, the healthcare is something like that. You got the good, you got the bad, and you got the ugly. And if there are any surgeons in the audience, you can certainly relate to the model over there. It says, you may run the risk, my friend, but I do the cutting. So I'll tell you what I think is good, what's bad, and perhaps what's ugly. Now, you've asked me to talk about the Canadian healthcare system. I have to remind you that Canada has 10 provinces, 3 territories, and the delivery of healthcare in each one is different. But it's not that different that if I tell you about Ontario, is where I come from, that you can apply it to the rest of Canada. Canada has about 36 million people roughly, and where I come from, Ontario, it's about 13, 14 million people, just to give you an idea what I'm talking about. There was a survey, it was done by the Americans, you probably know. They call it the Commonwealth Fund Survey. I'm not sure what they call the Commonwealth, but regardless, it's a survey that has 11 countries. And if you look at the survey, it was done very recently in 2013, and out of the 11 countries, Canada's number 10. So if you think I'm going to come up with a magic bullet here, don't hold your breath. As you can see, the United States is number 11, but that's in 2013. Since then, they brought in Obamacare, and they've done much better. Now they are number 10, and we are number 11. Having said that, you can see on the very bottom, Canada, get the laser here, Canada spends about $4,500 per capita. The US is about twice that amount. So if you think by spending more money on healthcare, you get better healthcare, not so. In fact, that's further proven by my next slide, where you look at the health expenditures versus life expectancy. If you look towards the far right, you can see where the US is and how much money they're spending, and a little bit further to the left, you could see Canada. with the Canadian healthcare system having a little better outcome in terms of life expectancy. So money doesn't always equate with better healthcare. So the good and the not so good. What are the things that we do well and what are things we don't do well? I was going to say we do hockey well, but you wouldn't be interested in that now. So what's good? Well, what's good is that our system is free. Nobody pays anything. And the not so good is that it is only free. And I'm going to tell you what that means. Back in 1966, they have introduced in Canada what's called the universal healthcare. So what that meant was that in Canada, everybody is entitled to free healthcare. Nobody pays anything. And then the politicians in 1984 came up with the idea that, well, we were going to bring in the Canada Health Act. And what the Canada Health Act said was that it's illegal to charge for care that the government pays for. So what does that mean? It means if, let's say, if I'm a cardiologist, you come to see me, you have angina, I look at you, I treat you, I submit my bill to the government, I cannot charge anything above and beyond that. Almost any diagnosis that's available is treatable by a doctor, and for that I can't charge any more. In fact, it's against the law. So whoever comes to see me, I submit the bill, and that's all I get. I can't say, well, I'm going to give you special care, or today I've done an ECG on you. Rather than doing this tomorrow, I do it today, I'll charge you extra. I cannot charge anything extra, and I cannot accept any money from the patient. Gifts are okay, money's no. I always look forward towards Christmas. So socialized medicine, I think you know what that means. It means basically the government pays for everything. In our case, hospital care is completely covered in Canada, as are the physicians. All the doctors are paid, and we have a coverage for patients that are 65 and over. I'd say most drugs. I don't want to get into it, it's a long story, but by and large, most drugs, if you're 65 and over, they call them the seniors, and you will have medical coverage. The most expensive in all this is the hospital care, obviously. At one time, the doctors used to cost a lot of money, but now, as we get an older population, it turns out that the drugs have overtaken us. So number one would be hospital drugs, and then the physicians would be the least expensive out of all this. So what we have is in somewhat of a paradox. And the paradox is that we have a system that's publicly funded and privately delivered. What does it mean? It means publicly funded, the government is paying the doctors, but I, as a doctor, I'm a private businessman. I run a private business when a patient comes to see me. So I rent an office or I buy a house, that's mine, I pay for that. The nurses that work in my office, I pay for that. The soap in the bathroom, the toilet tissue, so on and so forth, I pay for everything. So I run a private business in order to deliver a publicly funded health care. It's kind of interesting. There are some advantages to it. For example, there's no advertising. I can't advertise. Exception to that would be plastic surgeons, dentists, and optometrists. But doctors, by and large, someone like me, I'm a primary care physician, I can't advertise. I also have no bad debts. In the United States, you submit the bill to various insurance companies or perhaps privately or what have you, or same thing in Canada, and you have bad debts. I don't have any bad debts. The government pays for all my services. I didn't say they pay enough. I just said they pay for the services. There's no profit incentives for private insurance, and by and large, about 75% of the Canadians have private coverage. So you can take third-party coverage for drugs, for example. So people that are not 65, there's private insurance available for them to pay for the drugs. Also, things, for example, dentists are not covered, and neither is optometry. For the patient, what's good about the patient? Well, all the health care is always available. Anytime you get sick, you go to the hospital, you get healthcare coverage. There's no financial burden to the patient. You don't have to have extra money in your pocket when you go to see a doctor. You don't have to worry about billing. Everything is for free. And everybody's treated the same. It's all equal. And like I told you before, it's illegal to charge for extra care. Let me give you an example. A patient of mine, who also happens to be an orthopedic surgeon, had a patient who was a CEO of a company. He was a VIP, and he had a bad hip. And he needed hip replacement, and he was told he'll have to wait 6 to 8 months until he gets hip replacement. He said, gee, how come I have to wait so long? The orthopedic surgeon said, well, the hospital pays for so many hips per month, and whenever those are exceeded, we then have to go to the next month. So there's only so much available. So the guy said, well, how much is a total hip? So they called up the company for, I don't know, like $3,000, you can get a hip prosthesis. He says, listen, I'll buy the hip prosthesis, put the hip into me, I'll get better faster, I'm more productive. Not only that, but the hip that you were going to put into me now can go to somebody else. The doc said, I'm okay with that. So he took it to the local hospital, and the hospital looked this over and said, no. The doctor says, why not? He says, it's not fair to somebody who cannot afford it. So that's the system we have. So even though you have money, you can't go forward. So everything that's medically necessary, there's no private pay, as I mentioned to you before. You can't buy higher quality care. Just as I mentioned to you before, you can't take out extra money. You can't have, if you want to use the word, bribe somebody and say, listen, I'll get you something extra. It's all covered, except for we have home care and drugs, but I'm not going to go into that. And you can't pay anything extra either to the doctors or to the hospital care. So when you get into the hospital, if you like to have your bed sheets changed every day instead of every second, that's no-go. You can't pay. So who pays for free Medicare? And the risk of being a bit risky, may I use this analogy? So the analogy is, what's the difference between free sex and sex you pay for? Turns out free sex is more expensive. And I think Medicare is the same way. If you have if you have free Medicare, it is very expensive. Somebody has to pay for that. So who pays for that? Well, it's sneakily, I'm getting ahead of myself, sneakily sort of rolled into our income tax, believe it or not. There's a couple of other places where it's quite evident. Number one is, for example, if I employ people. I have about 5 people working in my office, and for each of those people, I pay up to 2% of their wages. So I pay for that. When people fill out the income tax, somewhere in there, there's buried, it's not called a health tax, it's something else. I'll look it up for you if you wish. And what it boils down to, I got some numbers, I'm not going to go through all of them, but the average family pays around $12,000 a year through various income taxes. Someone like myself, I have a bit of a higher income. I pay about, if for a family of 4, about $37,000 a year. Now, what exactly does that mean? The average Canadian salary for 2016 was about $50,000. So you pay one way or another. Universal socialized health care is not free. You probably saw this slide. Thank God for global warming. We got these giant icebergs coming down the east end of Canada. They're absolutely beautiful. They get stuck on these shoals and people come along and they take pictures. They're absolutely gorgeous. There are different ways of getting remunerated. As you know, on the far right, you have what's called activity-based, and that is basically what you see is what you get. Every time you see a patient, you submit a bill to the government, you get paid. On the far left, you got a combination of system, either capitation or outcome-based. Capitation system, for those of you who don't know, and that's how I practice, every time a patient comes to me and signs up with me, so they agree that I'm the doctor and I provide full service. For that patient, I get a set amount per per year, whether I see them or not. The amount is based on age and sex. It's got nothing to do with how sick you are or what sort of diseases you have. This has certain advantages and disadvantages. The disadvantage to the patient is that I would like to collect healthy patients. On the other hand, patients that are sick, they may have a tougher time finding a doctor because the amount a doctor gets paid is the same. So these are sort of the pros and cons. How do we practice in Ontario? In Ontario, it's about, if you look at the middle, about 85% of Ontario, we have a mixed capitation, fee-for-service, and salary. By and large, doctors working in hospitals tend to be salaried. The rest of us are either fee-for-service or a mixed capitation. Everybody, of course, wants to know sort of what do doctors make. This is a sort of a short list of average. This is the average. The darker colors you see would be roughly the overhead, what they're paying. Obviously, everybody here would like to be an ophthalmologist, but make no mistake, there's somebody up here that's not representative, and that would be the radiologist. They make more money than God. So what's good? We have introduced electronic billing. Roughly about 20 years ago, we used to submit, every time somebody comes to see me, I used to fill out a piece of paper, submit it to the government, and based on that I get paid. Now it's done all electronically. So what does it mean? Anytime I submit something on the billing form, you have age, you have sex, you have diagnosis of the patient, and obviously it provides a superb data list. It's collected in Ontario by a group called ICIS. That's ICIS. Don't make a spelling mistake, not ISIS. If you look it up, you'll find out what they do, how they collect the information. I think that is a tremendous help because now people can sort of project as to what's sort of the prevalence in terms of diagnosis, the sickness, and so on and so forth. I didn't know this until I did the talk. Canada has more lakes than the rest of the world combined. I thought that was very interesting. Again, what's good? We have the introduction of electronic medical records. The government has subsidized doctors to adopt an electronic medical system. I think it's absolutely fantastic if the Hungarians are going to do anything to move forward and to keep a pulse on medicine. I think the electronic medical records are the way to go. You can plan preventions, you know who's vaccinated. For example, if you have diabetics, you can very quickly run a search. It's very easy to do. For example, the government knows much better than I do how many of my diabetic patients have met their hemoglobin A1C. How many patients of mine have colorectal screening done, who had breast screening, so on and so forth. I think it's absolutely fantastic. The other good thing that we have introduced is a thing called information data sharing. That's done at the hospital levels, so all the hospitals in Canada report information back to a central group where they talk about frequency of admissions, what their diagnosis, where the patients have come from, so on. It's a huge data gathering system where the government can plan various programs and so forth. So I think that is something we do very well, collecting this information. I think it's excellent. What's also, did I skip something? No. What's also good? Acute care, we're very good if you get sick. If you end up in the hospital, end up in the urgent care or anything life-threatening, you don't pay for anything. Ambulance scoops you up, you don't pay a penny. I think acute care is excellent. The other thing we do very well is a thing called cancer care. Cancer Care Ontario was introduced recently. It's a government-funded, specially funded program where the government looks into, for example, breast screening. They'll notify the patient when breast screening is due. If they have an abnormal, for example, mammography, they tell the patient when to come next, so on and so forth. I think Canada is sort of leading in terms of breast cancer survivors. So that we do that very well. So the good, well, there's some things that are not so good. There's bad things too. We have long waiting times to see a specialist. Total joint replacement, for example, is about 6 to 12 months after you see the consultant. First you have to see him, and then you have to wait about another 6 to 12 months. The example I gave you before, my orthopedic colleague, I talked to him about 2 days before I left. He has about 400 people on the waiting list currently. His other colleague has about 200 people waiting list to get on to have a total joint replacement. So it's not all, you know, it's not as great as you think it is. I ran a program about a month ago in Ontario, and I talked to a number of endocrinologists that are sitting at my table. And I said, just out of curiosity, let's see if somebody with low sodium, or maybe they have SIADH or some other problem and I can't figure it out. If I refer them to you, how long do you wait? They said, it's about 4 to 6 months to see an endocrinologist. Otolaryngologist, it's about 6 to 8 months. If you want back surgery, you might as well die forever. MRI, roughly about 2 to 3 months, and you say, geez, you know, if you have to wait 2 to 3 months, why don't they build more MRIs? Well, the problem is that it's not market-driven, it's budget-based. The more MRIs they build, the more it's used, the more they bill for it, the more it costs. So it's all, government has a hand in it. So interestingly, you know, talk about waiting times. My orthopedic colleague also reminded me that one place where the waiting times are a fair bit shorter is in Toronto. And that is where the local municipal parliament is. That's where the politicians are. Somehow or other, I don't know why, but the waiting list is shorter there. I'm sure it's not the same in Hungary. Ugly? Well, we got long waiting lists for surgery, but we got unemployed surgeons. If you're a surgeon, the only way you can work is if you're affiliated to a hospital. Of course, the hospitals, let's say they already have 4 surgeons that do orthopedics. Sorry, we have no job for you. So we got the long waiting list and we have unemployed surgeons. The RCMP, Royal Canadian Mounted Police, they get preferential treatment. That's because their healthcare comes from the federal government, not locally from the province. Workmen's Compensation Board is a different scene. If you're a prisoner, if you're in prison, you get immediate health care. Again, that's supplied by the federal government. So you got a sore back, you go to prison. I put down dogs and cats. Why? If your dog or a cat needs an MRI, you pay for it, and you get it done tomorrow. If I want an MRI, if I really want it quickly, I live about an hour and a half from the US border. I'll hop across the border, take out my wallet to pay $400. I'll look around, see where I can get a good MRI, and I'll get it done just like that. So that's socialized medicine. It's good, it's not so good. In some ways we hate it, but I think it's as good as it gets, and I think if for something that you hate, you can make something work that somebody hates. So I'm going to show you very quickly. This is a hate relationship, and it seems to be working. This particular fellow, Flavio Briatore, he's the president of Renault, and this guy has a girlfriend. And what's interesting about that is, well, this is not a love relationship. This is a typical hate relationship. What happens is he hates being lonely and she hates poverty, and it seems to work. So not all things are bad. If you thought being in Canada or being in Hungary as a doctor is a bad thing, no, I think there's a lot more worse jobs than being a doctor in Hungary or in Canada. I don't know how much they pay this guy, but it must be an awful lot. So finally, I think in my opinion, just sort of to summarize, where the crux of it is, and I think where people can make a difference, is probably at the primary healthcare level. In Canada, the entrance into the healthcare system is done at the primary healthcare level, where you see a primary practitioner. The speaker before me talked about evidence-based medicine. That's one of the things we're quite proud of. We do evidence-based medicine, and we do it well. We have various guidelines that we have to implement at the primary care level. So, for example, about what the blood pressure guidelines are, the guidelines for lipids, diabetes, vaccines, so on and so forth. These are all evidence-based, and we have to implement it. Now, what do you mean you have to implement? So what does that mean? So how do you know you're doing a good job, or maybe just saying you're doing all this? Well, it turns out we're monitored by the College of Physicians. So every so often, randomly, someone gets picked. I got picked about 3 years ago. Someone comes to my office, looks through my charts, and says to me, show me 10 of your diabetics. And they look to see what the hemoglobin A1C is, and they see, does it meet guidelines? They look over to see who's vaccinated, who's not. Look to see who has their blood pressure on target or not. So I can't just practice willy-nilly what I like to do. These are evidence-based targets that we have to meet, and they are strongly endorsed. One of the ways to endorse it and one of the ways to implement it is by the increased use of electronic medical records. I think I told you that. It's very easy. You can run searches. You can find out who meets targets, who doesn't meet targets, and also that goes into a central data collection. We got continual medical education, but I'm sure everybody else does. I personally have to collect about 250 hours every 5 years. And one of the things that's very big right now, and it's coming in vogue, I put the website on the bottom. It's called Choosing Wisely. We have guidelines, for example, for orthopedics, for rheumatology, for hematology. And when you go and look at the website, it tells you, for example, what are the things that you're supposed to do and what are the things that you shouldn't do. Let me give you a very quick example. As a rheumatologist, let's say somebody comes in with back pain. Typical things people do, you go, you have an x-ray done. Well, it's not recommended. Unless you have red flags, unless there's certain things that a patient meets, you shouldn't be doing it. So this is what's called choosing wisely, and it really helps, I think, cut down on all the unnecessary tests. And I've certainly seen it. I spent some time with some of my colleagues where here people go and have routine x-rays done. Here, go have an x-ray done, have blood work done. And when you say, why are you doing it? Well, just know that's not right. Sometimes I think it does more bad than good. So I hope I've given you a little flavor as to how we practice in Canada. It's not all that bad. I told you we got a lot of lakes, we play hockey, and if you're ever in the neighborhood, you can always come back and I'll take you fishing. And maybe on that note, I'll call it a day. Thank you very much. Thank you for having me.